Okay, so I know today was an RV talk. Will happen, but in a couple of weeks, and I'll use today for diastolic function. I don't have that set of slides with me here. So we'll start with this one. So many of you are familiar with the topic of diastolic function. Diastolic function, strictly speaking, is a lot of things that can be assessed. It was described first invasively, looking at the rate of LV pressure decline during the isovolumic relaxation period. It's looked at also as the rate of rise of LV pressure with respect to filling, how fast the pressure rise as filling of the ventricle takes place during diastole. And it is possible to derive numbers variables, but you need high fidelity pressure catheters to do that. You also, at times, if you're going to go for LV stiffness, need what we call conductance catheters that measure volumes and pressure at the same time, and ideally with alterations of the loading conditions. For example, inflating a balloon in the IVC or lifting someone's legs and things like that. So if you're not doing any of that stuff, which is the gold standard, and for several reasons it is not done in the cath lab nowadays except in a research setting, you are left with measuring pressures. And there are several pressures that can be measured, but I want to make the point that an elevated pressure, diastolic pressure, is not always equal to diastolic dysfunction. Echocardiography and any modality that seeks to assess diastolic function would like, or ideally should be able to give you information about different pieces, relaxation, stiffness, in addition to pressures. But it is the part that is most reliable is the pressures piece. Though in some situations saying that the ventricle has abnormal relaxation is straightforward, for example, in a heart with depressed ejection fraction. So what are the pressures that can be measured in the ventricle? We have a pressure very early in diastole, the lowest pressure that can be attained. This is called the minimal pressure, very close to zero. Most reliable if you use a high fidelity pressure catheter, but fluid-filled transducers may be used. Then the mitral valve opens. You have a gradient between the atrium and the ventricle. Filling of the ventricle takes place, and in a normal heart, relaxation is complete by this point in very early diastole. So you have a phase with a rather rapid rise in LV pressure. The diastolic pressure reaches a plateau, then gradually rises up till late diastole when the atrium sends another surge of blood that produces what we call an A-wave rise in LV diastolic pressure, and it ends up with the EDP. So the pressure that is frequently reported in cath reports is the EDP, end diastolic pressure. As you see, it stays for a very short duration of the cardiac cycle. And end diastolic pressure is abnormal in patients who have diseased hearts, diastolic dysfunction, normal volume, intravascular volume status. In the course of diastolic dysfunction and in the development of this disease, the earliest pressure to be abnormal is EDP. Later on, the situation gets worse in terms of, say, worse myocardial disease. The intravascular volume expands. Earlier diastolic pressures is the pre-A pressure. The pressure in the ventricle just before the atrium contracts gets to rise up as well. So these are the diastolic pressures that you can measure in the ventricle. It is possible to get what we call a mean LV diastolic pressure. This is a temporal mean, a mean that takes place of all the pressures that are happening in diastole, and you measure them. Again, limited publications in the use of this mean LV diastolic pressure, but has been done with high fidelity pressure catheters, not with fluid-filled transducers. What about atrial pressures? The atrial pressure is shown here in blue. And so during systole, the atrium is filled with blood, the valve is closed, so the atrial pressure has to rise. Till it exceeds ventricular pressure, we get what we call a crossover point. Here the two pressures are equal. At that point, the mitral valve opens and filling of the ventricle takes place. So the ventricular pressure starts rising, but the atrial pressure starts to fall. This is the Y descent. And then the atrial pressure continues to rise again. Why? Because there is flow of blood from the veins into the atrium. You get another positive pressure in the atrium, an A wave. This time is due to atrial contraction. And then the pressure drops again with an X descent. To get these nice clear signals, you usually need a catheter in the LA. However, some pulmonary venous wedge pressure recordings can also be decent and show you these. What pressures can we measure aside from the V and the A waves? You can measure a mean LA pressure. Notice that the mean left atrial pressure is lower than both V and A waves. And this is the pressure you ideally want to report, not the V, not the A, though it is possible, of course, to report both. Mean LA pressure, LV pre-A pressure, mean LV diastolic pressure, mean wedge pressure are all very similar to one another. There can be variations in different diseases, but these are the pressures that you can measure and report. Okay. So when we talk about diastolic function, it is good to have a framework where you can say what the normal looks like, what the abnormals look like. And in a normal heart, you have this rapid decline of pressure, as we just mentioned. You have predominant filling in early compared to late diastole. The velocity rises fast, the velocity drops fast. The E to A ratio is more than 1, and the time interval between closure of the aortic valve and opening of the mitral valve is the isovolumic relaxation time. If you go back to the auscultation skills, this time interval, we get to pay attention to it, for example, in patients with mitral stenosis. The time interval gets shorter as the left atrial pressure goes up in more severe stenosis. So the concept of the IVRT is not unique to echocardiography. What I want to say, it has been reported with phonocardiography before. If the ventricular pressure is slow to decline, you end up with a higher minimal LV pressure. As a result, with the NLA pressure that is not elevated, that gradient, that space of the curve is smaller area. And then you have a lower E, a longer time for that E to dissipate, a longer time for the velocity to rise, a longer IVRT. Now comes the time of atrial contraction. The atrium has not emptied much blood. The atrium follows the Starling mechanism, if you would, and now contracts more forcefully, gives you that larger A wave. So this pattern is often referred to as impaired relaxation pattern. Important to pay attention to the word pattern. Impaired relaxation can be present with an inflow that looks like this, and also with an inflow that looks like this. So the word pattern means we are talking about the mitral inflow and what it looks like. How about the annular velocities? The annulus recoils away from the apex in early diastole and in late diastole, and you get these annular velocities E prime and A prime shown in lowercase. So say this individual needs a higher cardiac output or ends up in a situation where they get more decompensated, perhaps because of fluids, and now the atrial pressure rises. The result is a predominant filling in early diastole and a pattern that looks very similar to this one. The major difference, of course, is the higher pressure here, which is the driver for why the pattern looks like this. Decel time shorter, acceleration time shorter, and conversely, acceleration rate, deceleration rate get higher, and the isovolumic relaxation time gets shorter. However, unlike the mitral E, the E prime stays down, and this is why it is useful to look at the E prime. It is not a mere mirror image of the mitral inflow. Notice also that in this situation, LV and diastolic pressure is pretty much elevated. And as a result, this is the afterload that the atrium has to contract against. The A prime velocity goes down. So if you see this pattern in someone with cardiac disease, it signifies a late stage of diastolic dysfunction, elevated early, mid, and late diastolic pressures. Okay. Can we make inferences about filling pressures and how they change just based on mitral inflow? If I know whether the heart is normal or abnormal, I can. But if I do not know, I need something else to allow me to move from saying this is a normal or an abnormal heart. How can we determine if diastolic dysfunction is present? Of course, the gold standard we said is cath and all of that info. But practically, day to day, if you look at a patient with cardiovascular disease, CAD, multiple wall motion abnormalities, that's not a normal heart, okay? How about someone who has pathologic left ventricular hypertrophy, aortic stenosis, hypertensive cardiovascular disease? That's an abnormal heart as well. Systolic dysfunction clearly manifested by a depressed EF, and we are not talking about those athletes who are engaged in aerobic activity and you're looking at lower limits EF. We're talking about a diseased heart, say with an EF of 40% or so. A HFpEF diagnosis, if established. One wants to be careful about an established diagnosis of HFpEF. Many times we get cases referred and the referring doctor says it's HFpEF. Want to be more careful and more critical for this group of individuals. Some Doppler signals are very useful by themselves. They will tell you there is disease, and we'll look at these. And then if I have something else to tell me there is an abnormal myocardial function, this could be LV, longitudinal strain, could be mitral annulus S prime velocity, could be the mitral annulus descent. All of them are measures of longitudinal function, some with higher reproducibility and feasibility than others, particularly as you go to simpler methods as opposed to strain. So you've heard about strain probably before. You want to look at it in multiple views, apical 4, apical long, apical 2. You look at your polar map, you see if there are errors, if the tracking is adequate, and so on. My objective today is not to talk about strain, but to point to the importance of taking strain into consideration when trying to decide whether someone may have abnormal myocardial function. Clinical history is very important. Both the 2009 guidelines and the updated guidelines in 2016 emphasize that the assessment of diastolic function should start after the interpreting physician or sonographer have looked at the clinical history of that patient. Example where a clinical history can mess things up is shown on this slide. So ignore the title here and let us just look at the mitral inflow. Very high E, minuscule A, restrictive filling, okay? Well, the reason this looks the way it does is the patient has just had electric cardioversion. There is atrial stunning, atrial contractility goes down, mitral A is very small. So this is not true restrictive. This is what you can refer to as pseudo-restrictive, and one should not use it to draw inferences now. Notice what happens after atrial function recovers 3 days later. The peak A velocity is now 78 centimeters per second, and as a velocity and as a contribution to LV filling is much higher than what it was before. Paying attention to technical details is important. So we said clinical is one piece of it. I just gave one example. There are many others. Paying attention to technical details is important, both on the side of the sonographers as they are acquiring the signal and on the side of physicians when they are going through these signals. Just because you have something presented to you does not mean you have to use it. Let's take a look. So we're looking here at septal tissue Doppler velocities. If we ignore where the sample volume is, if we ignore the gains, the filters, the compression, and look at each of these 4 panels, A through D, you can measure E prime and you can measure A prime. you will end up with different values. Something that is maybe slightly less than 6 here, to something that is approaching 10, to something more than 10, and so on. None of these, this is not a good signal. Notice where it is present. It is not at the septal side of the mitral annulus. It is almost distal area or region of the basal inferior septum. If you look here, what is wrong here? The gains were turned down too low. Here the filters were cranked up too high. So these are not satisfactory signals. Sometimes we are in a hurry, both acquiring signals and also trying to go fast through a study, and you end up not paying closer attention. The same can be said about lateral tissue Doppler velocities. You can get E prime and A prime. Doesn't mean you have to use it. Look carefully at where it is. This is in the LA, not useful. This is in the base of the lateral wall. Part of this signal is even outside the heart altogether. The reason you are getting some annular velocities is because the heart is swinging, and sometimes you are catching these velocities. Okay. Thirdly, there are approaches that you use for patients in sinus rhythm and approaches that you use for patients who are not in sinus rhythm. I want to know what the rhythm is. I want to identify early diastole as well, because we're talking about mitral E prime velocity, mitral annulus E prime velocity. Look at this signal. This is from a patient with a left bundle branch block, depressed ejection fraction. So we have a biphasic isovolumic contraction velocity. You have an S prime ejection velocity. Then you have a biphasic isovolumic relaxation velocity, and there is E prime and there is A prime. Wrong to use this as annular E prime. Next, we need, as we are going through the study, to look for specific signals that tell us that LV filling pressures are elevated. It is important to look for these signals and think about what they say before you come and conclude LV filling pressure cannot be determined. Okay, what are these signals? We'll talk about pulmonary veins atrial velocity. We'll look at changes in mitral inflow. We'll talk about a mitral L velocity and comparison of mitral and tricuspid inflow. These are signals from a patient with HFpEF. Look at mitral E, look at mitral A. It's a restrictive filling pattern. The mitral A is very short duration, a small peak velocity, very rapid deceleration time. Look at the pulmonary vein signals. Diastolic much higher than systolic, rapid descent in that diastolic velocity. And look how the atrial reversal is pretty large velocity, both in duration as well as in amplitude. Of all the Doppler signals that we talk about, and we say Doppler velocities are affected by age, well, that atrial reversal velocity has been shown not to be affected by age. So if you have an atrial reversal velocity that is the way you see it in this case, particularly when you compare it with mitral inflow, that tells you that late diastolic LV pressures are elevated. Because as the atrium contracts, it faces a high LV EDP, so that mitral A will be small. But now there is less resistance for the atrium to eject blood backward into the vein, and you get a big A reversal. How feasible it is to get these velocities if you spend enough time, particularly in the outpatient setting. The consensus of what is published in the literature from reputable labs is in excess of 80%. ICU yield is much lower. There is the mitral inflow, looking at what happens to the mitral inflow with Valsalva. So during the straining phase, venous return drops, left atrial pressure drops, the transmitral pressure gradient falls, and you end up with a low E, high A. So why did it change? Because the LAP is up, and that got unmasked by Valsalva. The challenge with the Valsalva is getting a patient who is cooperative enough and ability to standardize the effort and as a result, its sensitivity may not be that high, but its specificity, if properly executed, is pretty good. One has to pay attention to the location of the sample volume, shouldn't be moving up and down, which can happen with respiration, so perhaps slightly more into the funnel as opposed to towards the annulus. Also important, I'm showing it here with a sweep speed about 60 some as an example. Ideally you want to do a 50 sweep speed and you start from the beginning till the patient releases the strain, so you can compare what is happening throughout the whole maneuver. A third thing we talked about that we can use is looking at mitral and tricuspid inflow. When you have a cardiomyopathic heart, the myocardium is abnormal everywhere in general. And if the pressures are normal, then mitral inflow and tricuspid inflow tend to mirror one another, usually with an impaired relaxation pattern on both sides, low E, high A. But this is taken from a patient with a cardiomyopathy and actually different pressures between the LV diastolic and RV diastolic pressures. You see an EDP of about 30 and a pre-A pressure of about 18. That has resulted in a restrictive mitral inflow pattern. If you look at the RV diastolic pressures, the pre-A is about 8, the EDP is about 12, and it's a low E, high A. So if I'm looking at this diseased heart and I'm looking at this difference, why do they look differently? The odds are high they look differently because LAP is up, but RAP is normal. You can have other things that point you in the same direction with respect to the LAP as well as to the respect of the RAP. Last but not least is the mitral inflow L velocity. This was first described by the Mayo Clinic group. They had a group of individuals who had abnormal LV relaxation in terms of depressed septal E prime velocity, high LAP, and slow heart rate. That velocity, if abnormal, will usually be 50 centimeters per second or above. If you see it, it's an indicator of diastolic dysfunction with elevated LAP as well. Word of caution, in normal hearts, particularly when the heart rate is slow, you can have an L velocity, but at that time it is usually 20 centimeters per second or less. Has also been reported both on the septal and lateral annuli, but there is much less work and probably less reliable conclusions may be reached using these. So now we have gone through that exercise. I looked at the clinical info, I looked at the 2D findings, I looked at the Doppler signals that have been acquired, I looked at these 4 specific signals we talked about, and nothing is pointing me in any direction what to do. So now let us look at these 4 signals. The E prime velocity on the septum, the lateral wall, the average E to E prime ratio, the peak TR velocity, and the LA volume index. Previously, it was thought that annular velocities alone may be enough to put patients into a category of abnormal relaxation. However, several observational studies, some of them are epidemiologic, some of them are from studies seeking to define normal values, as the NORSE study. This was a multi-center European studies where patients were carefully selected to be normal subjects. Scanning followed a dedicated protocol and analysis was done by the core lab. So I am emphasizing all good things that allows you to have greater reliability in these data. And basically what they showed is you can have a 7 centimeters per second or less in normal individuals. This was a 499 patient study in close to 20% of cases. And a lateral E prime that is less than 10 centimeters per second in about 15% of cases. Clearly you do not want to be wrong in 15 to 19% of time if you rely on these only. Also, you can somewhat narrow this erroneous overestimation of diastolic dysfunction based on velocities only if you apply age-specific cutoffs. The problem with the age-specific cutoffs is if you try to group a number of studies together and then do some sort of meta-analysis through these, and then come up with the values. This way, you end up with wide confidence limits. So the consensus of the writing group was this alone by itself should not be used to define an abnormal function. How about then other variables? So the other variables that were looked at were average E to E prime, more than 14. And this was present in less than 1% of that NOR study of the normal subjects. So if abnormal, it's very specific for disease. A TR velocity more than 2.8 per second, and an LA maximum volume index of 34 mLs per meter squared. Older guidelines in chamber quantification from 2005 had looked at a 28 mLs as the upper limit of normal. The updated ones in 2015 corrected that and recommended that 34 mLs. Having said that, the upper limits of a normal LA volume index not only depends on the population that you study, but also depends on the methodology used to get LA volumes. NOR showed some differences, and up to 10% of patients normal subjects, not patients, can have a value more than 34 mLs. As a result, LA maximum volume index by itself should not stand. So the bottom line is you want more than one signal, the more confident you are in your diagnosis. Some of these parameters reflect an elevated LAP or a consequence of a previously elevated LAP as the LA maximum volume index, but we want it to be more specific. And these are the cutoffs that you have and how many of them should be abnormal to call diastolic dysfunction indeterminate or normal. Clearly, as I acquire the signals, I want to get all of these signals, so I minimize the indeterminate call because I don't have a TR jet, or because I foreshortened the LA and now the LA does not look like it was correctly acquired. I want to get good tissue Doppler velocities so they can be used, and so on. So recognize that the indeterminate yield is also affected by the quality of the exam and how compulsive these elements have been acquired. Aside from the annular velocities, you can say that all good echocardiographic studies should have a TR jet because we want to report PA pressures, and should have a good look at the LA volume, which is a predictor of outcome in many patient populations. That's a normal heart from a patient referred with a diagnosis of a murmur, and if you look at the variables, everything is normal. Blood pressure was normal, heart rate was normal, not a challenge to say this is normal diastolic function. Okay. We had to apply the algorithm that we used there. There is a patient who is 63-year-old with recurrent dyspnea on daily activities. They are diabetic, hypertensive, chronic renal disease, and even at the time of the exam. So I have a lot of reasons that can lead to heart failure, be it with preserved EF or even with depressed EF later on. When we look at the apical views, apical 4 and apical 2, you have pretty big atria, but LV volumes look normal. LV ejection fraction looks normal. We want to look at regurgitant lesions because regurgitation can affect the mitral E velocity, can affect the decel time, and so on. And not much of a regurg there in terms of aortic or mitral. Clearly you want multiple views. It is not just this view, but I chose this for the sake of time. And there is the mitral inflow, and there are the E to E prime ratio, septal and lateral 20 each, peak TR 3.6. So in summary, I have clinical data that point to someone with cardiac disease, hypertensive, and plus the other risk factors, an E to A ratio that is between 0.8 and 2, an average E to E prime ratio of 20, a big LA even without any actual measurement, and a TR of 3.6. So if we look at an individual where we now know has myocardial disease and we want to establish what their filling pressures are, the 2016 update has this algorithm, and it starts with the mitral inflow. Our patient sits in this middle group where we need to look at other variables beyond the mitral inflow. So if we look at all of the variables, in this case, all of them turn to be abnormal. So 3 of 3 are positive. That takes us to grade 2 diastolic dysfunction with elevated LAP. Someone with a history of a previous MI presents with recurrent episodes of dyspnea on daily activities, hypertensive, diabetic, hyperlipidemia, no history of pulmonary disease. So again, you have a setting where it says this is a cardiac case or not going to have a normal myocardial function. We look at the parasternal lung axis view, clearly abnormal LV function, depressed segmental wall motion abnormalities. Okay, apical 4 and apical 2, a big left atrium, and an inferior wall and inferior septum that are akinetic. So it's an abnormal heart. How about the mitral inflow? A very high E, a very small a. If you look at the pulmonary veins, predominant flow in diastole and a rather a reversal that is more prominent compared to the mitral A. So clinical data points to cardiac disease, EF depressed, E to A ratio more than 2, pulmonary vein systolic to diastolic ratio, BHU used, the velocity or the time velocity integral is less than 1, and a big left atrium. And now we are in this box, E to A ratio 2 or above, and that is grade 3 diastolic dysfunction. The actual wedge pressure recording is shown in this case with nice A and V waves, and the mean wedge pressure was 22. Okay, that's another example of a patient with a restrictive filling pattern, depressed EF, pretty high TR velocity, and a very nice wedge pressure recording as you see here with the mean wedge of 25. Again, nice A and V waves showing the quality of the wedge pressure recording. Somebody with a heart failure, preserved EF, a big left atrium, a mitral inflow pattern that we call impaired relaxation pattern, peak E about 70 or so, a mitral annulus velocity of about 4.5 to 5, and if you look at the signals that we have a big left atrium, we have an E to E prime ratio that is increased, but the TR velocity is incomplete. This is not a TR that you necessarily put your full trust in. And based on that, you would conclude that LAP is elevated, and here mean wedge pressure is about 28 millimeters mercury. Notice a pretty high V signal, V wave, and a high A. The mean, as we said, is always lower than both, and this is a very nice wedge pressure recording as well because you see these different waveforms in it. By the way, not every large V that you see in an LA pressure recording or in a wedge pressure recording is due to MR. A stiff left atrium will lead to a high V velocity. We looked together with other sites in Europe, Canada, and South Korea at the accuracy of this approach in 450 patients, and we compared clinical assessment. Clinical assessment included a look at the clinical exam data, the chest X-ray, and when available, the serum biomarkers. And we noticed that echocardiography was more sensitive, more specific than clinical assessment. These were done by cardiologists, so I would say probably a better case scenario than if you take all physicians looking at patients. Decent positive and negative predictive values and accuracies, and all of these were highly different, statistically significant, that is. Also, if you look at subsets based on EF, the presence of obesity and other conditions, in general, echo accuracy was more. Worth to emphasize two particular groups. A group of patients with a preserved EF, here we defined it as 50%. Notice clinical accuracy is 64 compared to 84%. So echo is not perfect clearly, but much better than clinical assessment only. Also look at patients with pulmonary parenchymal or vascular disease. This was not a large number of patients, only 71 of the 450 cases. And again, echo accuracy was much better, 81 versus 54%. Okay, so we've talked about a common approach where we use signals that we get every day. Are there other signals that can be used and analyzed to draw inferences about LV diastolic function? The answer is yes. So one of these is looking at LV relaxation surrogates during the isovolumic relaxation period and during early diastole using myocardial strain rate. Similar to LV strain, you get it from multiple views. You get a global value for the segments that you visualize, and you can measure this as systolic strain rate, so that's why it's below the baseline by convention. Then during the isovolumic relaxation period and during early diastole, then late diastole. That signal in particular had a very significant relation, not a linear one, with the time constant of LV relaxation in animals. That was highly significant, and also with negative dp/dt. This is from a patient actually, and it allows you to see the timing of events in terms of isovolumic relaxation, in terms of early, late diastole, how strain and velocities look like. So strain is mirror image opposite to what you get with the mitral annulus velocities. So the mitral annulus velocities at the septum is shown in blue, at the lateral side of the annulus in red, and in purple is the strain rate. So this is early diastole, so the early diastolic annulus velocity, E prime, A prime. This is the early and late diastolic strain rate. And this time interval between the aortic valve closure and the mitral valve opening is the isovolumic relaxation. And notice you have these downward facing velocities in the annulus velocity signals, but an upward signal during isovolumic relaxation. You can do this with several software systems, if you would. There are efforts towards standardization of systolic strain, but little in terms of diastolic strain rate signals. And here it's showing you that with the VVI system with early and late diastole, and this is systolic strain. That signal can also be analyzed and has relations very similar to IVR in terms of direction, but magnitude not as tight. Similar to the E to E prime ratio, you can do E to SR IVR ratio, significant relation. Open and closed circles are patients with normal and depressed EF. And more importantly, this is from a group in the Netherlands looking at the utility of that early diastolic strain rate signal during isovolumic relaxation period, not early diastole, in predicting outcomes in a group of patients presenting with their first STEMI. The chi-square model was 40 when they threw in the TIMI score, all other standard echo measurements. There was a significant increment in the chi-square value to about 53 or 54 or so when they added the SR IVR. So pointing not only to a diagnostic but prognostic utility. We are interested in LA pressure estimation, so it makes sense. Let's go to the LA strain curve and let us see what it allows us to do. So during systole, the left atrium is filling with blood. This is corresponding to the increase in LA volume and to the rise in LA pressure with the V wave, if you would. This is the LA reservoir strain. Then you have the mitral valve opening, the LA volume goes down. You have an early diastolic, not very clear here, strain, and a late diastolic strain. That late diastolic LA strain is related to LA contractility or LA booster pump function and can also be analyzed. You can analyze it from several regions and you can average them as shown here. Ideally, you want to do it from many points, from all four walls, so that you get a good representation of the whole left atrium. Turns out that LA signal during systole, the reservoir function of the strain, if you would, has a significant relation with EDP and with wedge pressure. This was the earliest publication from a Japanese group that included 100 patients, normal and depressed EF. They used high fidelity pressure transducers, and you see a very tight correlation with both variables. When these investigators analyzed the relation, whether it was good in depressed as in normal EF, the relation was better in depressed EF as opposed to normal EF. So what are some of the limitations for strain rate signals, diastolic strain rate signals. You need higher quality images and higher quality signals. You want to get as many segments, so if you do not see the myocardium well in different views, that's a limitation. Clearly, there is a need for someone who's experienced for acquisition and for analysis. It will take you more time than, say, velocity. And if you're looking at very fast heart rates, then with the frame rates that we currently use with speckle tracking, you can miss events, for example, those that occur during the isovolumic relaxation period. So these are the limitations for the use of these signals. How about specific patient populations? Atrial fibrillation is an important group of patients, and the guidelines in 2016, the update emphasizes decel time 160 milliseconds or less. If somebody has a depressed EF, look at the peak TR velocity, likewise more than 2.8 meter per second. If there is no pulmonary disease, then the reason that peak TR is up is likely an LAP that is elevated. If someone has diseased heart, not a normal heart, the lone AFib, if you would, are not in this discussion. Look at the acceleration rate, look at the IVRT, look at the decel time of the pulmonary veins, look at the septal E to E prime ratio, look at reduced beat-to-beat variability in mitral inflow. All of these are very useful. So before you look at a case of atrial fib and say cannot assess diastolic function, look carefully at all of that info that you have in terms of clinical setting, in terms of quality of signals and consistency of the observations across the different variables. This is work that I did with Dr. Quinones back in 1996, looking at the relation between decel time and LV filling pressures in patients with atrial fibrillation, and you can see that when EF is depressed, there is a significant inverse relation shown by the solid circles and the solid line, as opposed to the scatter plot that you see all over the place here when EF was more than 45%, despite a wide range of filling pressures. So decel time is useful when EF is depressed. We often have to measure septal E and mitral E if we want to do, or lateral E prime and septal E prime if we want to do E to E prime ratio. Because of the variability in AFib, it is advantageous to use velocities from the same cardiac cycle. One of the available ultrasound systems allows you to do so. So it's a dual Doppler probe. In the same cardiac cycle, you can get E and E prime as you see here. The impact on the accuracy is shown on these graphs. If you're just averaging a bunch of beats, the relation, while significant, shows a wider spread. It gets much tighter if you are using the same cardiac cycle. Similar to the L-wave concept that we talked about in sinus rhythm, there are few studies that brought it up as well in the presence of atrial fibrillation. This is a patient with a high mitral E, a rather fast ascent or acceleration of the mitral E. Look at a peak TR that is about 3.5 meter per second and very low annular velocities. Collectively, all of the features in this case tell us that LAP is elevated in this patient with atrial fibrillation. Mitral annular calcification, if moderate or severe, is another challenge for assessment of diastolic function. You want to look at the severity of MAC, mild, moderate, or severe, taking into account not just the brightness of the signal, but also the extent of the signal. The more extensive the calcification across the annulus, the more likely it will produce some sort of a smallish, if you would, annular area that can affect the annular velocities. And that's an example of the correlations that were seen in that study from Dr. Abu Diab here in that institution, and Dr. Zagbi and Dr. Shubrolo. And you see significant correlations for mitral E to A ratio, isovolumic relaxation time, E to E prime ratio, not particularly useful if you compare it to these two variables. But by themselves, there is still a wide data spread, and therefore a good approach is to identify values that clearly place you into either a normal category or an abnormal category and something in between. Then look at the IVRT. The cutoff here was 80 milliseconds or less. So yes, even in patients with mitral annular calcification, you can still provide reasonable assessments of LV filling pressures. And these are examples for patients with normal and elevated filling pressures based on the mitral inflow and IVRT. Hypertrophic cardiomyopathy, another challenging group of patients. You can look at LA volume index, peak TR velocity, average E to E prime, pulmonary veins atrial velocity signal. If a patient does not have significant MR and HCM, you just look at the preponderance, and if all of them are abnormal or 3 or 4 are abnormal, then you conclude filling pressures are elevated. If not, then we are looking at a normal LAP likely. If only 2 available parameters, both should be abnormal. If they take you opposite directions, that's an indeterminate. So more of a common sense approach, but just be more selective of which signals you consider. If there is MR, then look at the peak TR and AR velocity. Why the pulmonary vein late diastolic velocity? It's because mitral regurg affects early diastolic signals, but not late diastolic signals. And that's an example from an early stage of diastolic dysfunction with increased EDP based on the atrial reversal velocity, but a normal E to E prime ratio. A more advanced stage is present here. Notice the salmon, the brightness at the septum at the site of the leaflet septal contact, and a high E to A ratio and E to E prime ratio, septal and lateral. A more advanced degree of restrictive filling. This is a finding that if you see in HCM patients predicts hospitalizations for heart failure. There is that L velocity, and notice how small these velocities. The scale has to be brought down to 2 centimeters per second ticks so that you can look at these E prime velocities. So very advanced stage. Left ventricular assist device patients, we see them increasingly, and the effects of the LVAD obviously is to produce reverse LV remodeling with a decrease in ventricular dimensions, which you can reliably measure in parasternal views, and if you can do volumes, it is possible. This is an algorithm that was developed with Dr. E. Stepp and his team, starting again with mitral inflow, and then looking at RAP, PA systolic pressure, LA volume index, and E to E prime ratio. If the ratio is more than 2, you need only 1 parameter to call elevated LAP. If it is 1 or less, 1 parameter is enough to call a normal LAP. If it's in between, you need now 2 of 3 parameters. And these are the parameters you look at. Notice the cutoff values are very similar to what we have in the guidelines at 33 ml as opposed to a 34, and E to E prime ratio of 14, a PA systolic more than 40, but this is when you have added the RAP. And that's an example of a patient who has a normal LAP with an LVAD, whereas this patient has a PA systolic that is clearly elevated without adding the TR. 38. Notice the E to A ratio, the LA that was enlarged. Diastolic stress testing is one of the elements in the guidelines recommendation, and it is looked at in a group of patients where you have not reached a decision based on rest findings. Ideally, it's with a supine bike. It is possible to acquire it post-treadmill exercise, but you need to acquire the signals after some time has passed so that you get less merging of E and A velocities if you're using the treadmill. With the bike, it is not much of a challenge to acquire as you proceed without much merging. So these are the baseline findings before the patient exercises. E prime septally is 5, the mitral E is 50, a TR of 2.6, so we are 26 millimeters mercury. Now the patient exercises, E prime stays abnormally reduced. It's a diseased heart. In diseased hearts, E prime is much less dependent on LA pressure and the transmitral pressure gradient, so it stays down. The mitral E goes up from 50 to 95. You can even identify that L velocity. And notice now you have a much higher E to E prime ratio, clearly more than 14. The peak TR goes to 3.5 or 49 millimeters mercury. So this is a patient who has heart failure preserved EF, normal pressures at rest, but with exercise, you uncover the abnormal diastolic function. This is one of the studies that looked at the correlations. There are very few studies in terms of exercise echo Doppler parameters against exercise cath, there was a decent correlation in these patients who, from the investigators who measured mean LV diastolic pressures. Importantly, if you look at the prognostic value of E2E prime with exercise, it adds compared to clinical data, compared to exercise EKG, compared to echo wall motion score index. Why do we grade diastolic dysfunction? We grade diastolic dysfunction because progression of diastolic dysfunction is a predictor of subsequent development of heart failure. This is an epidemiologic study from the Mayo Group, where if a patient had progression to persistently moderate or severe diastolic dysfunction, the heart failure events rates was at the order of 11 to 13%. If they progressed from normal to a mild dysfunction, so now we are talking that impaired relaxation, normal LAP pattern, the heart failure over that period of time was a 7%, whereas if they stayed normal or were abnormal but became normal on follow-up on a repeat echocardiogram, the heart failure event rate was of the order of 2 to 3%. So it makes a difference. So in conclusion, for correct assessment of diastolic function, we recommend, of course, you use the guidelines, consider the clinical findings, consider the 2D data, look at the technical quality of the acquired signals. If you have somebody who's symptomatic and you're having inconsistency between their symptoms and the findings at rest, think of a diastolic stress test. If it's an indeterminate situation and the question is a patient referred with a possible diagnosis of heart failure or dyspnea of unknown origin, then may well recommend proceeding to a cardiac cath. I will stop here and take questions.
Why is it that the atrial reversal duration changes as opposed to the A duration? What does it mean when you take the atrial reversal minus A?
Okay. So the A velocity of the mitral inflow and the atrial reversal in the pulmonary veins are related to LA contraction. Okay. So when at the time the LA contracts, it has two pathways, if you would, to send the blood. One pathway is across the mitral valve into the left ventricle. The other one is sent it back into the pulmonary vein. In somebody with increased end diastolic pressure, the end diastolic pressure or the late LV diastolic pressures are the afterload that the left atrium sees. Similar to the ventricle, if you increase the afterload of the ventricle for the first few beats before homeometric autoregulation takes place, LV contractility drops. Okay, so EDP is up, the afterload for the atrium is up, mitral A drops. It's a harder thing for the LA to send blood across the mitral valve. But now there is nothing contracting in the pulmonary veins, so it's easier for the LA to send the blood back into the vein. So because this atrium is contracting forcefully, trying to deal with this increased afterload, a reversal is of a higher amplitude, and the ejection from the atrium into the vein will last longer than the ejection from the atrium into the ventricle. When I have both signals, I can compare how long this is taking place compared to that. And the longer this is compared to that, the higher the LV EDP. It's a direct relation. The magic number happens to be 35 milliseconds.
One caveat to that one. One little caveat to this, which is very nice concept that works very well. In fact, it's probably one of the oldest reports in diastology with Doppler, because it was done, my goodness, I think before you were a fellow, by Dr. Hatley.
Was Liv Hatley, yes. Rosvoll and Hatley.
One caveat, if you have a very short PR, so if you always look at the PR, because you have people with PR intervals of, the so-called short PR syndrome, then just because of the PR, the mitral A will be aborted quickly. So that's the one caveat that you want to be careful with, because that could give you a false positive. One comment, Sherif, in some of these patients that have kind of like I cannot assess diastolic function because of signals or whatever, I have taken the position that if the if there are elements on the 2D to suggest heart disease, and the LA is enlarged and the PA pressure is up, I will go for it.
Yes.
Even if the signals are yucky and I cannot
Yes.
put head together with anything else.
And that is okay, and
Yeah.
it goes with the
It goes
guidelines.
with the guidelines, yeah.
Because you will have here two abnormal values, the TR and the LA volume.
Right, right.
The pure diastologist, if you would rather put more confidence in the diastolic velocities themselves as pulmonary vein, mitral, and tissue Doppler as opposed to a circumstantial evidence. But having said that, that was tested in a large multi-center study, 450 plus patients, and the accuracy is decent when you just use these two signals. But again, in the proper context, so you need to know is, are you looking at a patient with heart disease or not? Okay. Thank you all. How are you? Yes. Do you want me to go back? So